I think it is time. Yes, indeed, we are live. Dee Hodge, you are the first person to join me over here. And Monique Hebert, thank you for being here with us. Good afternoon, America, live coast to coast from CNY Fertility in Colorado. I'm Dr. Randy Fink, the Clinical Director of IVF Services here at CNY Fertility Colorado and the Medical Director of CNY Fertility at the Miami Center of Excellence in Miami, Florida. And gosh, we sure are happy to have everybody with us today. Straight up 4 o'clock means 4 o'clock in the mountains, 3 o'clock on the West Coast, and 6 o'clock for our friends east. 5 o'clock in the central time zone. Good to see everybody with us. We've had quite a week in the world. I haven't seen any news today. I imagine things up in the Northeast have been somewhat tumultuous, I think, given the current state of political affairs. But I know that all of our friends in the central U.S. and extending up towards the Northeast have been dealing with all kinds of weather-related stressors. So our thoughts and prayers go out to each of you and in all your journeys and in everything that you do and in all ways that we can help. So happy to have you with us today. It's normally Fertility with Fink and Friends. You are my friends today. I don't have a special guest. Last week we had Ryan Rolla, a certified registered nurse anesthetist from here in Colorado Springs, join us, and we had really great feedback. Maddie Morris photo says, "Hope you're getting as much snow as us in Utah." Well, guess what, Maddie? We have no snow to speak of. In fact, well, actually, it's 35 degrees outside right now, but it was 60, I think 65 degrees here yesterday. So it's a little bit kind of kooky, the weather here in Colorado. We got great feedback from our last visit together last week. One of the things that I am challenged with is that I love to see, oh my gosh, Mrs. BT Oliver is in Monument, which is about 20 minutes up the road. And she got snow. Well, you know what? It just goes to show you this is a funny place we live. I'm challenged by the fact that I love to get questions and I love to answer questions. And I think, that's one of the great things that we can do here on these lives is to be able to try to address everyone's questions. But sometimes I have a guest and then we go to talk about the things that the guest is talking about. And it's frustrating not to be able to get to all the questions. So I apologize to all those questions that we can't get to, but we will certainly try on a day like today. So the other thing I wanted to, a couple of things I had just kind of been on my mind. One, it's just really trying to be thankful for all the little things that we often overlook and that really can make a difference in our lives. It's very hard to not get caught up in all the negativity, especially in the fertility world where we're challenged day in and day out by people having results that weren't intended or things that we weren't looking for, as opposed to positive pregnancy tests. It's hard to lose sight of the fact that what we're doing really makes a difference. And I'm not just talking about what we're doing as clinicians, but what you're doing as clients and as patients in order to try to bring together a family, because there are few things in the world that really are more meaningful than having and being surrounded by those you love. So I'm glad that we are able to be a part of your lives in that. And again, I just want to say thanks. So we've got a couple of different Instagram feeds here. We've got Facebook and YouTube and LinkedIn over here on this side. Looks like we just lost a little bit of signal over here. So let's see if we can't try to fix that. Let's see. We're going to get rid of this Wi-Fi and see if that does better. Okay. Well, trying to reconnect, but we'll keep. There we go. Now we're back. We lost a little bit of a feed there, so we switched off something, and hopefully now everything will work so great. 1 in 6 people face infertility globally, according to the World Health Organization, says my dear friend William, and I believe that that is. I believe that that is true. And you know what's most interesting is that the number of folks facing infertility really hasn't changed over the last 20 years. It's always been pretty bad. But it leads me to think that we're not doing enough to be able to help people. And I would say that that is one of the things that is most meaningful to me working at CNY, is to be able to offer this kind of treatment at a price point that everyone can afford, because it should not be something that is reserved for only those who are very wealthy. The other thing that's been on my mind, I wanted to say thank you to all those people who sent their thoughts and prayers to my family, for my father, who has been quite ill. He is an older gentleman who had a fall and fell onto the corner of the bathtub and broke 3 ribs. Didn't get around very well to begin with, but then as a result of that, was in terrible pain, got pneumonia, had fluid blood buildup around his lungs, then got COVID on top of it in the hospital, and maybe wasn't as treated as well as I would have preferred in the hospital. He may have used up some of his 9 lives, but thanks to your prayers, he is now in a rehab facility. He's doing much better, and he even said, "Hey, are you doing that fertilizer with Fink thing again on Tuesday?" So here we are, fertilizer with Fink, and happy to be of service. All right, well, let's see if we can't start asking a few questions here, answering a few questions. Colette says she had her transfer today. It's the 4th transfer. So, gosh, that is a big emotional trial to go through. What can I do to help this baby implant? Trying to stay stupor, idle, minimal movement here, but I did bend down to grab the Instacart delivery. Well, I think that's okay. You know, after a transfer, we tell folks that we want you to take it easy for 2 days. And what I usually tell them, what I mean by that is no alligator wrestling, no skydiving, rock climbing. If you're here in the Pikes Peak region, please don't climb Pikes Peak. It just means nothing strenuous. People are able to travel. People are able to walk around. I don't recommend that you go to the gym. And I say, if you're going to travel, try to take it easy. Let somebody else carry the suitcases or the steamer trunk or whatever else maybe you brought with you to our facility. But lumberjacking and extreme snowboarding, that kind of thing, we want you to refrain from, really just for 2 days. A day 5 embryo or a blastocyst, that's about the time that an embryo will start to, in nature, start to implant in the uterus. A day 3 embryo is usually in the fallopian tubes around day 3 and works its way down into the uterine cavity. So it can still be a few days after that embryo goes in, whether it's a day 3 or a blast, before that embryo decides to implant. The most important feature is that the lining itself is sufficient to kind of be the world's best baby blanket, as I think of it. We want that lining to be about 6.5, 7 millimeters is ideal. Below that, sometimes there are challenges, even though with an endometrium that is less than 7 centimeters, sometimes we can do an ultrasound and actually look at the blood flow that's going to that uterus and see that even though the lining's thinner, that the blood flow appears to be adequate. That's probably the most important feature. There are some supplements that I think can help. And if we run out of time here, I think we're going to talk a little bit about supplements if we can. I think maybe what we'll do at some point is reserve a special episode just to kind of review the supplements that we recommend for you. So actually what we've done here is that is that if you're familiar with a book that's called It Starts with the Egg. It's really one of the quintessential works about the biochemistry of egg quality and of fertility, and about the things that we can do by taking supplements that may affect our own biochemistry. And so there are evidence-based guidelines that we have really poured through the book to find for you so that you don't have to, and really come up with a curated list of what those supplements are, best costs, ideal dosages. And here in our Colorado location, we have that on a list for you. If you would like to have that list where you can kind of just click one button to get to it all, feel free to message me on Instagram. I have figured out now that there is another inbox that I wasn't aware of on Instagram, but Randy Fink MD, and we're happy to send you that protocol that tells you everything. One of the things that's often forgotten in an embryo transfer cycle, and it's one of the things that I consider important for our transfer medications, and so we have included it on our transfer excuse me, on our transfer protocol list, is L-arginine. L-arginine is a supplement that is not said to be a big help with egg quality or with freezing, or rather with retrieving eggs, but rather improves blood flow to the endometrium. So L-arginine is one we recommend. Vitamin E makes a difference there, CoQ10, and of course, vitamin D. Happy to send you that protocol with the ones that we recommend. If you don't take a prenatal, you should do that as well. But so that's one of the first things that I look at when trying to find out why transfers haven't been working. And the other thing that concerns me a great deal is, when was the last time you had your uterine cavity evaluated? And for many people I talk to, it was a long time ago. Oh, well, I had a saline sonogram in 2000, or maybe in 2018. I think that you should have your uterine cavity evaluated every single year, right? And that is either with a saline sonogram or with a hysteroscopy. Please do this. That will be the first thing that I ask you if we have a consult about why a transfer didn't work. Very important. Colette also says, I had to bend a bunch of times to put everything away, and now I'm paranoid. You don't have to be, Colette. We are a pretty resilient species as humans, and if bending down was something that was going to cause us to not get pregnant, I don't think our species would have perpetuated. So I think you're in okay shape there, but very good question. Stay encouraged. All right, what else do we have here? Thoughts on transferring 1 versus 2 embryos? Well, I got to tell you, so there are guidelines about how many embryos to transfer. And these are things that we take very seriously. There are many people who come here and they want to transfer multiple euploid embryos. And of course, a euploid is a tested embryo. It's one that has undergone PGT testing. And the recommendation is, no matter what age you are, if you've got a euploid embryo, that you transfer 1 embryo. We want you to be pregnant, but we want you to be pregnant 1 baby at a time. What happens, I think, with a lot of folks is that after going through this process, there is such a drive to just be pregnant, be pregnant, be pregnant. I want that positive pregnancy test, whatever it takes. I want that positive pregnancy test. And so I don't care how many embryos I have to put in, as long as I get that positive pregnancy test. Well, the issue is that when we put in multiple embryos, it doesn't necessarily increase the live birth rate. It increases the probability of having a positive pregnancy test. But since the live birth rate is not increased there, what it's doing is increasing the possibility of pregnancy loss. And that's something that we really just don't want to have to face. So, with multiples, there are significant risks for preterm labor, preterm delivery, prolonged NICU stays, um, effects of severe prematurity, cerebral palsy. Um, the list goes on and on. So, for many reasons, what we want is for you to have a single healthy baby at a time. Twins are cute. You can dress them up, dress them the same. They follow you around. Oh, they are really cute. And everybody knows people who are twins and they've done very well with their lives and so forth. So how can that be a problem? Well, I can tell you that from the NICU standpoint, it's a big problem. And really, if we can avoid you or provide you the happiness of the positive pregnancy test, but avoid you the heartache of the NICU stay, then we really are doing a good thing. Now, there are some guidelines depending on your age and depending on the types of embryo you have, whether it's a day 3 embryo or what we call a cleavage stage embryo, or if it is or if it's a blastocyst, where more than one embryo may be appropriate. But feel free to ask us about that. In general, I would tell you the better solution is to think about one embryo in most cases until you're really above about 38 years of age or so. So let's see. Felicia says, I got my midways, my estradiol was 43, and I did a modified natural. Well, yeah, it's a good question there. So 2 types of transfers. There's a medicated cycle for an embryo transfer, and then there is a natural cycle. And we've talked about this before, so forgive me if I am being repetitive here. But in a medicated embryo, well, Mrs. Vince, nice of you to finally join us. In a medicated cycle, we give you 6 to 12 days of estrogen, followed by 6.5 days typically of progesterone, and then you get your embryo transfer. So we are medicating every aspect of that transfer in order to control for every single variable. In a natural cycle, your ovary produces an egg, and as that follicle grows with the egg inside of it, it makes estrogen. And that estrogen increases the lining of your uterus so that it becomes hospitable for your pregnancy to implant. We can trigger the ovulation, which starts the clock on when we will do the embryo transfer. And that's a modification of a natural cycle, or some people will ovulate on their own. And when they do, that tells us, okay, now you ovulated, so that follicle is going to start to make progesterone. The follicle becomes what's called a corpus luteum, and the corpus luteum makes progesterone, and it's that progesterone that organizes the lining. And the fact that you're making your own progesterone is one of the things that may make a natural cycle a better choice for many people, because it can improve the pregnancy rate, it can decrease the miscarriage rate, and it decreases the risk of certain types of pregnancy complications later on, specifically blood pressure complications. Now, Felicia, you asked about the estrogen level. We do check them. We check those estrogen levels. But the truth is that in a natural cycle, the estrogen level in the blood is really not important. What is important is that that lining got thick enough to be able to to support that pregnancy at the time of transfer. We will give you extra estrogen based on a number, but to be honest, I would not lose too much sleep over the estrogen level. We do check the progesterone levels because your body's making that progesterone. We want that progesterone to be high enough. So it's not uncommon that we will supplement your progesterone. But from an estrogen standpoint, Felicia, I think you can feel pretty comfortable. Let's look over here. Oh, my friend Erica Plotkin. Hello, Erica. Nice to see you. What is my opinion on home pregnancy tests and testing before the beta? So Erica had a day 3 fresh transfer tomorrow. Morning is the beta. She broke down and tested today, still getting negative results, which is 10 days post-transfer. Well, there's a couple of things there. So a home pregnancy test will um, be accurate to a beta HCG of roughly anywhere from 30 to 50 as far as a quantitative value that we would otherwise check in your blood. At day 10, after a day 3 embryo transfer, you may not have enough HCG in your blood to trigger a urine test to be positive. So, I know how hard it is to avoid it because, you can get it at the store and all you have to do is pee on it. And oh my God, I can't wait anymore. Can't you please just give me some information? The waiting is the hardest part. But, day 10 after a blastocyst transfer ought to be about the time that we are looking for a positive beta in the blood. But it's a little bit longer than that for a day 3 embryo. So I would take what you see with a urine pregnancy test with a grain of salt. So hopefully that's helpful, Erica. But nevertheless, fingers are crossed and our prayers are with you for sure. Let's see here what else we have. We're going to go back to this side. Thanks. Oh, from I can't read. That's too small. Thanks for all of you at CNY Fertility. We love it. By the way, if you didn't see if you don't follow me on Instagram this week, or in the last few days, we've taken back to being able to try to personally make the positive beta calls for all of our at least locally monitored patients here in Colorado. All the other offices may not be able to do that, and for our global patients, unfortunately, we don't have the ability to be able to see all those betas at the right time. But at least for our locally monitored patients, it gives us the greatest feeling in the world to be able to sit down all together as a team, our clinic team, our OR team, even the embryology folks get involved, and we call patients and we tell them, congratulations, you're pregnant. If you didn't see what that looks like, I posted it on my Instagram the other day. We did that for a bit, and then for some other reasons, those calls stopped, but now we've made the decision that here we are going to do it. So my hope is that we will be calling you with your positive results, because not only does that make you feel good, but oh my heavens, it is the really one of the best parts of the day, and certainly one of the best parts of the job. So thank you for letting us be a part of your world. Let's see. How can, and this comes from Kate Mitz. Kate Mitz 21, how can an AMH of 0.5 affect an egg retrieval? So the AMH is called the anti-Mullerian hormone. And as many of you know, the AMH is our marker for ovarian reserve. And there is an age-related nomogram that goes along with ovarian reserve. So as we age, or mature is probably a better word. Let's go with that. As we mature, our ovarian reserve will drop. We are born with all the eggs that we will ever have. And so the AMH is kind of a marker, a qualitative marker. It gives us a number, but it qualitatively tells us, well, roughly about how many eggs might be left. So it suggests to us the kind of response that you will get from medications associated with IVF. It does not say anything about your ability to get pregnant on your own, and nor does it say anything about egg quality. But it suggests that what we're going to need to do to try to get the ovaries to respond. So the classic wisdom with a lower ovarian reserve was that we wanted to use as much medication as we could get, that we wanted to use these very high doses of medication so that we could pour as much on the ovary to try to get the ovaries to respond. What we know now is that probably doesn't work. That more medication is not better. That aggressive does not necessarily mean that we're doing the right thing for a bunch of different reasons. So typically, what we do is we go with lower doses, sometimes even mini dose protocols, with a lower AMH. The other thing that we're looking at now is, and in fact, Dr. Faruqi and I are even studying it, using a different type of medication than the standard antagonist type medication that we use with your IVF protocol. So, with IVF, we give you some FSH, so that's either Gonal-F or Follistim. And we give you some LH, which comes either in the form of the low-dose HCG, the HCG LH, or Minipure. And then we give you another medication that prevents you from ovulating, and that's called an antagonist. And those medications, that's either ganirelix or Centratide, most commonly. Well, they're very expensive medications, and there's certainly nothing wrong with them because these antagonist protocols are really the standard of care. But we can use a low dose of medication that's taken orally. That's called, that maybe you've taken it before for other reasons, medroxyprogesterone acetate, or Provera. It's taken from cycle day 1 through the morning of the day of trigger. It functions the same way, but it doesn't suppress follicles, and there may be some other benefits to it as well. So we are placing a lot of our patients on the Provera protocol now, especially for those who have a diminished ovarian reserve. So it's one of the tricks that we might use with a lower AMH to try to help you produce the most and the best of your eggs. The only downside to that protocol is that we can't do a fresh transfer with it because the progesterone, remember that progesterone is used to prepare the uterine lining for implantation. And if we're messing with it with progesterone, it can change the way the lining presents for implantation. So we have to do a freeze-all cycle with that. Okay, Vince 21. Hope that helps. Let's see here. It looks like Ms. Santiago writes, I am looking for some advice since I don't know what to do. Well, then you are in the right place, my friend. I had 4 transfers, of which 3 were negative, and 1 ended up in a chemical pregnancy. Very sad. Of course you are and don't know what else to do. Well, you're going to try it one more time. First thing is I applaud you for your strength in going through this process. As far as sadness goes, I will say that this is a very emotionally intensive, it's a labor-intensive process for the emotions. And so I am proud of you for everything that you've done so far. And I can tell you that this entire community of folks will share really that same kind of love with you because it is not an easy thing to do. So the first thing I would say is, not knowing anything more about what kinds of embryos these were and percentages that might be associated with it and other factors. There are supplements that can improve the outcomes, the biochemistry of implantation. So I would strongly encourage you to look into those things. And again, feel free to send me a message on Instagram. I'm happy to send you that protocol. Secondly, when was your uterine cavity evaluated? We want to make sure that there's no polyps, fibroids, bands of muscle, scar tissue, anything on the inside of the uterus that may prevent that perfect little embryo from implanting. Thirdly, we think about endometriosis. Is there silent endometriosis? And there is now a non-invasive test that we can do that's called Receptiva that can help to diagnose endometriosis as opposed to the standard laparoscopy, which is what was required previously to diagnose endometriosis. And endometriosis affects the way the brain is talking to the uterus. It can affect egg quality. It can affect lots of things, but as it pertains to implantation, it changes the signals that's going from brain to uterus. So that's something we want to know and we would want to test for. We are also curious in that lining about chronic inflammation, and the Receptiva test can test for that as well. There used to be a test that we looked at much more regularly that was called an ERA. The ERA is the endometrial receptivity assay, but that was predicated on the idea that we have a very narrow window during which we can implant a pregnancy. But what we believe now is that the window is much wider than we originally thought, and the validity or the usefulness of the ERA has really been called into question. So, if you had asked me 6 months ago, I might have recommended an ERA for you, but now in most cases, I don't. So the Instagram name is Randy Fink MD, and I'm happy to send you that protocol or any of the egg quality protocols for those of you who are going to be going through the IVF process. Let's see what else we have here. How about a long drive? After a transfer, I think a long drive is really fun. You're mostly just sitting there. We usually tell you we want you to kind of keep yourself extra hydrated. So that means you're probably going to be stopping to pee more than you would be under normal circumstances. But a nice long drive is pretty good, as long as I think it's better if you're sitting there as passenger if possible. Kel's Gagnon or Kells anyway says, I have a 10 millimeter follicle at baseline before an embryo transfer. Doesn't matter. I heard there's a risk for canceling. Is it too late to switch to a modified natural? A 10 millimeter follicle in a medicated cycle really should not make a difference. For a natural cycle, it kind of depends on whether that follicle is secreting hormones and what your hormone level is, because we want the ovaries to be quiet. We don't want them to be doing something. And if you have a follicle that's already 10 millimeters in a natural cycle, it may be more quickly advancing towards ovulation, which might not give you enough time to build the lining. So I would say that in a medicated cycle, that's fine. Typically, we like those things to be under about 14 millimeters. In a natural cycle, I would look more carefully at what your hormone levels are. So good luck there for sure. When is it best to do lipids? This comes from Alex Navarra. When is it best to do lipids prior to transfer? So intralipid is kind of like getting an IV dose of the keto diet, and is good for people with elevated natural killer cells, or even people that we don't know. It's just a very potent natural anti-inflammatory, and so ideally we do it the day before transfer, but it can also be done on the day of transfer, and then typically weekly throughout the first trimester. Alex, good luck with that. And I just saw a note here from my friend Maureen, my old-time patient who had been a patient of mine since she was, I'm hesitant to even say, when I was a much younger man. And Maureen says, hi from our newborn baby girl who we got as a surprise between cycles, with lots of love and support from us. Well, that is just fantastic. And that makes me so happy, Maureen and Will. And Will says he likes my beard. And, that's really what's most important. It's that I look good. I may not be having a great hair day. And, sometimes that happens. But like I said, we just really have to be thankful for the little things. And that's that may not be about my hair or that I didn't put powder on to shine here, but that everybody's with me today. It's about almost 35 minutes after the hour. And this is Fertility with Fink and Friends, live from Colorado Springs and globally across the world, thanks to the internet. Sure glad to have everybody with us here. Let's see. Jen on the Facebook side says, if you use Instagram and Instagram. Wow, little Freudian slip there. If you're using estrogen and progesterone to bring on a new cycle, is it possible that the estrogen may cause your baseline estrogen to be slightly higher than normal? The answer is potentially. So what happens is that when we give you hormone, so we give you some estrogen, which helps to build up a lining. We give you progesterone, and the progesterone, as the progesterone level drops, that's the same signal that your body gives when you have ovulated and you haven't gotten pregnant. It's the progesterone that comes from the corpus luteum that as it drops down, that's what tells you to have a period. Slough everything off. Try again fresh next month. We'll do this again. That's the signal to have a nice normal period. So when we give you estrogen and progesterone to induce, to thicken up your lining and to induce a period, it is possible that your estrogen level, when checked, might be a little bit high. It shouldn't be dramatic, Jen. So it shouldn't be something that is that's terrible or that really ought to stop a cycle. And usually in that situation, if there's a question, then we have you back a day or two later to check the blood level again and make sure that it's going in the right direction as opposed to going up. I see my friend Meg Marnell in Syracuse has joined us. Meg is one of our very talented practitioners and runs the OR, really regulatory aspect for all of CNY Fertility. Meg, thank you for being with us, and thanks for all you do. Kathy Johnston says, what's CNY's guideline on transferring after C-section? The section was uncomplicated. Oh my gosh, but my son sadly passed away after he was born. Kathy, I am so sorry to hear that you and your family had to go through that tragedy. And there are few things in life, I think, that would be a greater stress. So all of our thoughts and prayers together are with you today and every day over your loss there. So, the question is, well, when to conceive after having a baby? And, this is something that is in debate. And I'll tell you the biggest reason for the debate has to do with the one manipulatable risk factor, the one, let's call it preventable risk factor for severe preterm birth is a short interconceptual interval. So there are folks who conceive almost immediately after having a baby. So when I was doing general obstetrics, we would see people back for a postpartum visit at usually 6 weeks or so. And one of the first questions is, what are we going to do about birth control? One of my fondest memories was a lovely couple who had IVF triplets in Miami. I still have their picture on my bulletin board. And she said, no, everything we've been through, we don't need to go through birth control because, we have such fertility problems. I said, well, things can change. Things do change. So maybe, just, for me, think about it, would you? And no, we don't need birth control. She had triplet boys, 3 boys in the house. And about 3 months later, she came back with a spontaneous pregnancy of twins, also boys. So within about a year and a half, she had 5 new boys in the house. At about the same time, her sister got pregnant also with spontaneous twins. So grandma got 7 grandsons inside of about a year and a half. So the things that can happen are pretty amazing. Fortunately, she had an uneventful twin pregnancy after that, but it gave us great cause for alarm because of anything that we can do to try to decrease the risk for preterm labor. And that's one of the things that even modern day obstetrics, we haven't had a lot of success in being able to try to preventing a short interconceptual interval, the interval between pregnancies, is really the only thing that we truly can do to try to prevent such a pregnancy from delivering preterm. So, I would say a minimum of 6 months. I think the uterus needs time to heal. I think the heart needs time to heal. Really, it's said that a delivery less than a year after a prior delivery increases the risk of a preterm delivery. So I think 6 to 9 months sounds like a reasonable time. And Kathy, our thoughts are certainly with you there. Let's see. Is a Gabby? Hi, Gabby Thorpe. Gabby asked, is a laparoscopy and an HSG suggested before IVF? And that's a really good question too. So I will tell you about laparoscopy. There are those amongst us who feel like a laparoscopy is one of the most important interventions that we can do in fertility. Personally speaking, I am not of the same belief, but I will tell you that um, in the earlier days of IVF, I'm told that you would often have your laparoscopy scheduled before you ever even met the doctor. And that's because laparoscopy used to be a critical part of the IVF or of the fertility workup. Um, Why is that? Well, because we could see if there was something mechanical on the inside with the tubes, blocked tubes, for instance, and we could even do the HSG test or test the fallopian tubes while under anesthesia so that you don't have to feel any of that. So there was some benefit to doing that. Nowadays at CNY, we know that most of the folks who are talking to me, at least in my consults, and I think in this company, due to the affordable pricing of IVF, are coming to us already knowing that IVF is going to be part of their journey. And I think that's a great thing because it is the fastest path to pregnancy. It's the most reliable path to pregnancy. And given our, if you're in a place where a cycle of IVF is going to cost you $30,000, geez, well, maybe then you do IUIs and you do lots of timed intercourse and all manner of other things to see if you can avoid having to spend the money for that. But at the price point being what it is here, many patients who are talking to us already know that IVF is part of the journey. And if that's the case, then I would say laparoscopy is not, I don't consider necessary. If we need to test for endometriosis, we can do that through non-invasive means. Many people have already had a laparoscopy, and if that's the case, well, I think then that's great. Then we already have a lot of information. And as far as the HSG, personally speaking, I do not recommend an HSG for people who know that they are going to undergo IVF. Now, what is an HSG? The HSG is the dye test. It is perhaps the least pleasant test that we do because it can be very uncomfortable. We're pushing some dye into the uterus while taking some X-ray pictures to show the uterus filling up. It shows us the shape of the uterus, and that's very valuable. And it also shows us that the fallopian tubes are open. Well, some people feel like, well, they need to do the HSG test because they want to make sure that there's not fluid that's in the fallopian tubes, and that's called a hydrosalpinx. Hydrofluid salpinx means tube. So the problem is that if there is a little blockage in a tube and we're pushing fluid into it, then one of the things that can happen is that it can look like there's a big fluid collection in the fallopian tube when really there's actually not. So the sentinel work in IVF and on reproductive endocrinology comes from a doctor named Spiroff, Leon Spiroff, and you may have heard of the Spiroff book. It's a classic standard textbook in gynecology. And Spiroff says that the ultrasound is the correct test for diagnosing or for finding a hydrosalpinx, and then an HSG is not the right test. So my personal preference is that if you're planning to do IVF, that you do not need to do an HSG. It's always voluntary. Some of our clinicians may recommend it, but I will tell you that if it's for IVF, it may not be the most important thing you do. So hysteroscopy, we can find out, HSG, we can find out things in other ways, and laparoscopy, we can find out things in other ways. Now, if it's the beginning of a workup for fertility and we're trying to figure out where the problems lie, then yes, an HSG is important because that's going to tell us, are the tubes blocked? Because if the tubes are blocked, then sperm ain't going to meet egg. And that's kind of an important thing to know because that means you won't be getting pregnant in the natural way. So what else we have here? So glad everybody's with us. Getting lots of fun questions here today. Veronica on the Facebook side said, I had one cycle with a fresh transfer, a subsequent polypectomy, but have a very large ovarian cyst, one that's 10 centimeters, and suspected endometriosis. Should I consider frozen transfer? Well, endometriosis, so if you have a 10 centimeter endometrioma, that's pretty big. That endometrioma is a collection of fluid or a collection of endometriosis fluid inside the ovary, when that's the case, that means the endometriosis is potentially affecting both egg quality, and it's affecting the way your brain is talking to the organs in terms of both making eggs and doing a transfer. Once we do surgery, and 10 centimeters is pretty big, and by that point, it is probably something that your gynecologist is going to recommend that you do have surgery on. But when we start doing things in the ovary, we can affect the blood flow that's going to the ovary, and that can have an effect on egg quality and on AMH as well. So certainly, I would say, Veronica, that's worth looking at. And a 10 centimeter endometrioma, you may want to think about doing something for, or certainly at least doing some endometriosis suppression before trying to do a transfer. And the endometriosis suppression is medication that is designed not to cure endometriosis, but rather to turn down the volume knob on the endometriosis the way the brain is talking to the uterus. And so typically what we do is 60 days of medication, and that's either with Lupron, it's with a medication called Orilissa, and sometimes letrozole, or a newer medication that's called Myfembree. These are what we do to kind of affect that. And I would certainly think at least some endometriosis suppression should be in your plan before doing an embryo transfer. I would definitely also consider a frozen transfer there for you as well, because I think that your outcomes will probably be better. Ashley Deb, or actually before that, what do we have here? MKid38. Howdy, kid. How valuable is a saline ultrasound for IVF? Very valuable. Very valuable. Because again, it drives me, I want to pull my hair out, and I don't have a lot of hair to pull out anymore. It makes me want to pull my hair out when I see folks doing transfers of embryos without having the cavity evaluated. A saline sonogram is a pretty quick and easy thing to do to show us that the uterine cavity is normal. You are investing a tremendous amount to make that embryo, not only financially, but emotionally and spiritually and mentally, everything else that goes along with that. So to do a 5-minute test with an ultrasound to make sure that the uterine cavity is normal, to me, just makes all the sense in the world. It used to be that you'd have to do a hysteroscopy, and many times these hysteroscopies were either very uncomfortable or they had to be done under anesthesia, and we can certainly still do that. Hysteroscopy can be done without anesthesia very, very easily, but a saline sonogram can be done really at any imaging facility, at just about any place that has an ultrasound. So Ashley Deb, does a blocked fallopian tube change the outcome of how many eggs can be retrieved? Usually not. The blocked tube is really just a roadblock that prevents sperm from being able to meet eggs. So we're stimulating the ovary, we're bypassing the fallopian tube. So the blocked tube really should have no difference in how the ovary is going to respond. Now, where it may make a difference is if there is fluid in that tube. And what do we call that? That is we were just talking about it. Don't tell me you weren't paying attention. That is a hydrosalpinx. And with a hydrosalpinx, that fluid in the fallopian tube can wash back into the uterine cavity and is toxic to an embryo. So if we know that you have a fluid collection in the fallopian tube, we want to remove that fallopian tube or block it so that the toxic fluid does not affect the embryo. Jen Malini says, I have a question. If both the egg donor um, own egg form embryos, can both be transferred? Okay. So I think what that means, Jen, is that if you are doing your own, oh, hi, Brandis. Brandis joined. I'm saying hello. Brandis, by the way, is doing her egg retrieval this week. So if you haven't looked at her Instagram, she is absolutely chronicling the whole thing for everybody. And we sure appreciate what you're doing there for education's sake and for helping other women to really understand what it's like for you as a provider to go through that. You are a rock star. But you know that. If you haven't met Brandis, call her. She will. She does a great job here. So anyway, Jen, I'm sorry, I got sidetracked. It's a little ADHD. If you are doing your own egg retrieval and you are doing a donor egg backup, and let's say that we get embryos both from you and from the donor, can we transfer more than one embryo, one from you and one from the donor? The answer is yes. The answer is yes. And at CNY, we will do that. There are some practices that will not, because the ASRM, American Society for Reproductive Medicine guidelines, suggest that when you're doing an embryo that arises from a donor egg, that you do one embryo for the reasons that we talked about before. So yes, you can, but you want to think carefully about it. And the truth is that it may be that, well, some also have ethical issues with, well, then, if you end up with twins and one's from you and one's from a donor, that creates problems down the line. Or you have one baby and then you're going to be wanting to do genetic testing to see, well, whose egg did it come from? It does create some issues down the road. So certainly something to think about. About how much Zaza Balloons, I like the name. How much is a sperm donor? There are commercial sperm banks all over the country. Probably the largest is the California Cryobank. There's the Fairfax Cryobank. On the CNY Fertility website, there are a list of the CNY approved sperm banks where you can get all the, you can go directly to their website and they really should publish the pricing. The one thing I will tell everybody who is thinking about doing donor sperm is that when you purchase that sperm, get the cheapest one you can, because all the sperm banks offer different levels of sperm to purchase. They can do IUI ready sperm. They can do IVF ready sperm. Pick the cheapest one, because CNY Fertility and our embryology lab, we are going to prepare that sperm for you anyway, and that's included in the price. There is no reason to pay extra for that from the sperm bank. Looks like Amanda Joe, hey, is asking about supplements. Do you have a post-transfer pregnancy supplement list or suggestions? Well, I would tell you the prenatal vitamin, pregnancy-related DHA and EPA, so that's basically fish oil, and there are a couple in particular I recommend, and I am happy to give you that information, Amanda, who we talk on Instagram sometimes. There are some people, so if you have polycystic ovarian syndrome, then what I usually recommend that, and as an OB, I would have recommended that you stay on myo-inositol, because that can decrease the risk of gestational diabetes and functions in many of the ways that metformin does, which many people take, which also decreases the risk of miscarriage. So hopefully that's a help there. And let's see, we got time for a few more questions. EC Cologne says, is it okay to be on Orilissa and letrozole prior to Retrieval, priming for 3 months, retrieval will be in June. Yes, you can certainly do that. So the Orilissa will suppress not only your endometriosis, but much of the hormone function as well. But then when you go into a retrieval cycle, we're going to be giving you all the medicines that we need to stimulate your ovaries to get you to produce eggs. So yes, being on endometriosis suppression prior to retrieval is something that you can do and also makes sense. Most of the time, to be honest with you, in my world, we're talking to folks who are being on suppression around the time of transfer, but you can certainly do that with retrieval as well. Let's see here. What's another option for progesterone in oil? Oh, you know it. They give you really bad bruising. Unfortunately, the progesterone in oil is really the best studied way of doing progesterone. If you do a natural cycle, frozen embryo transfer, then you don't have to use the progesterone in oil. So if you're doing a medicated cycle, there are some people who opt to say, I don't want to use that PIO, the progesterone in oil, because it hurts so bad. I really hate it. And understood, your poor booty with that is, becomes a pincushion. But it really does give us the best outcomes. There's some people who opt to just use vaginal progesterone, and I will tell you that the outcomes are definitely not as good with the medicated cycle. But with the natural cycle, your ovary is making your own progesterone, so the progesterone and oil shots are not necessary. Mocha Latte asks, do you recommend a saline sonogram after having a DNC back in October? I would say, a DNC is one of the things that can lead to scar tissue inside the uterus. And so it's absolutely a fact that we may be able to, that may cause some scar tissue. So I think it's worth looking into, especially if the cavity hasn't been evaluated. Let me point out here from Erica, my friend Erica Plotkin, who we chatted with before for the PIO. She has an auto injector from Union Medico, and I'm not familiar with them, but Union, UNION Medico, and it is the best thing ever. I don't feel the injection at all. That's big news. So dang, thanks, Erica. That's very valuable. Miss Casey Lynn asks, is it true a laparoscopy lowers your AMH? And the answer is no. Laparoscopy for diagnostic purposes is really just to take a look inside and see what we see. If we start doing some surgery inside the ovary, Erica says, by the way, that Union Medico is from Denmark, and it's called a Super Grip 90. I will remember that and share it. And maybe Erica needs a royalty or something for that. That's really appreciated. So laparoscopy, Casey Lynn, unless we start digging into the ovary to do some kind of surgery, it should have no effect on your AMH. Let's see, thoughts on, we're going to run out of time here, but let me just throw this last thing here. What's the thoughts on implanting a mosaic embryo? All day long, I would implant mosaic embryos. A euploid embryo tells us that you have a 60% chance of conceiving with that embryo. A mosaic embryo is where there is a disturbance in one of the cell lines, but it still gives us a 40% chance of having a baby with just as much likelihood that it's going to be a normal baby as your euploid embryo. So we transfer mosaic, low-level and high-level mosaic embryos, and I would encourage you to do the same. Kristen says, let them know it's for IVF and they will send all the needed attachments. A retroverted uterus, by the way, does not affect success with IVF. So hopefully that answers the question. I think all these social media places are going to cut us off here. We're running out of time. So let me just say thanks so much for being with me here today. It is truly a privilege and an honor to share your valuable time. Let's all try to be nicer to the world, find other ways to make the world a better place. God bless you all. We'll look forward to seeing you next Tuesday at 4 o'clock on Fertility with Fink. Have a great week.